So let's start with the capsular rectus. Training residents and fellows, of course, this is probably the step that we would agree requires probably the most skill in performing. It can be done, of course, in many different ways, but to do it just perfectly right, meaning a nice, centered, continuous capsular rectus, the perfect size, with the perfect design to ensure we have good capsule overlap over the optic, is not always so easy to do. I think, however, most of us that do a lot of surgery will agree that this is something that we can get pretty good at. But if you actually were to measure a surgeon's heart rate when we do phaco surgery, and you actually measure and see what points in time a surgeon's heart rate goes the highest, it's probably during the capsular rectus. That's the part where it probably gives us the most amount of concern. Maybe a few palpitations may start occurring if we have a difficult or complicated case. And although we do this in every case, that's the part where probably we require the most amount of attention. And we can't always predict exactly how that rectus goes until we actually are halfway through it often. So I'll put this up here just to kind of just point it out. And I just want to show a couple of videos here. Now, these are not representative, of course, of most cases. But I'm just showing a video here, which is actually someone with a bit less experience here. And you see the capsular rectus here, not quite centered. And as the rectus starts to run toward the inferior aspect of the capsular bag, you can see it starting to run out. And it runs out very close to the pupil margin. And the surgeon has to use some evasive maneuvers, the little technique basically, to redirect the capsule. You can see how far out it is on the red reflex. And it's going quite large and quite long. And of course, at this point in time, the goal of the surgeon is simply to get it done, to get a nice continuous rectus, even if it's going to be really large and not well centered. We'll talk about the impact of that, but of course, in this case, the surgeon was fortunately able to do it. These are really relatively uneventful, or should be uneventful, routine cases. But for different reasons, whether it's because the viscoelastic has been pushed out of the eye, as you see in this case, or perhaps because of surgical technique, or maybe because of the anatomy of the eye, including smaller eyes, or difficult chambers to form. See, in this case, the patient is starting the capsular rectus, the surgeon is starting the capsular rectus toward the nasal aspect of the globe. The rectus is starting to run out here toward the nasal iris here, and at this point in time, the surgeon is unable to really save it. So what do we do here? Well, we try to salvage the rectus here. Couldn't salvage it here, and therefore the rectus is going to be started again here on the temporal side, as we'll see by cutting it with a needle and restarting and rejoining it. I'm showing these videos here just to show that these are not common necessarily with experienced surgeons, but they do happen. They happen more commonly with inexperienced surgeons, and they can happen really in any case that we're not prepared for, and it can happen unexpectedly as well. Eventually, this capsular rectus was continued, but of course, because we've cut the capsule, it's no longer continuous. Of course, we know that the intumescent white lens is more difficult because of the intumescence in the lens capsular bag. The risk for capsular runout is higher. In this case here, this patient here has a pretty white intumescent cataract. The rectus goes fairly well, but as the surgeon starts to proceed superiorly, you see it starting to run a little bit. And you see the rectus is already larger than we like it to be. You saw that point in there where it started to run out a bit. There, of course, are ways that we teach to try to salvage the rectus, to redirect the vector forces, add more viscoelastic, shift the technique from a shearing technique to a stretching technique. But you see it continue to run out there, and eventually it's non-salvageable. And so one has to actually cut the capsule here to ensure that it's basically free. Of course, when we have an anterior capsule that's discontinuous, the risk of an anterior capsule tear is higher, as well as an IOL that doesn't sit very well. And then, of course, there's the dreaded Argentinian flag sign. On the immediate penetration of the anterior capsule, we see the capsule split after staying with vision blue, and we see the Argentinian flag sign.